So lorlatinib's another modern ALK inhibitor, an interesting compound that, like many next generation compounds, was designed to be better in terms of getting into the CNS, have greater ALK inhibition than the earlier generation therapeutics. We now know that lorlatinib's an active drug and has an approved indication in a second-line setting. Its role beyond that is unknown. This is just like all the drugs. At one point, we didn't know their value in the first-line setting. A randomized phase 3 trial versus crizotinib global study has already been completed, and we await those results. And I'd expect that to look like ALK in terms of being better than crizotinib, or brigatinib being better than crizotinib. We would guess lorlatinib would be better than crizotinib. Lorlatinib may have a little bit of a different toxicity profile, has the same toxicities we expect with ALK inhibitors, and one I left off before is transaminitis. That can be another challenge for some of our patients. This one can have a rare kind of mood affect change for patients, and that can be that can range from something that approaches confusion, delirium, to just not being themselves, not acting right. It's not a common toxicity, and it was seen certainly at a higher dose level in earlier studies. But I do think it's going to be a unique toxicity, albeit rare, that clinicians will have to kind of adjust and understand, something they aren't used to seeing with, say, alectinib or brigatinib. But I think if it's an active drug and the data continue to look good in the CNS especially, I think it's going to be yet another weapon in our armamentarium for fighting ALK lung cancer. Lorlatinib right now only really competes with brigatinib, in my view, as a drug to do after you've done something first line, and often it's alectinib. Lorlatinib's a drug we've had as part of a clinical trial, and so we have some experience with it. But I'd say brigatinib for most of the community is going to be the choice, because that's the one that's been around long enough for doctors to be more experienced with. Lorlatinib's a new drug, a new kid on the block, and it's going to take some time to get adjusted to that. But I think, like with anything, there'll be folks who try that. My guess is lorlatinib's going to be a third-line drug for most patients, is that doctors will follow the A, B, L sequence, and until we have data to show that lorlatinib should be used first line, I think that'll be the likely sequence. And I think there'll be some doctors who choose brigatinib first, followed by alectinib, followed by lorlatinib. But we'll see. I think it's like anything we've ever done in oncology. You got to get comfortable with these drugs, which can surprise you sometimes. And so you have to be comfortable giving medications that can help people but also hurt them, which none of us want to do.
When we're considering second-line options for patients who've first been treated with a next-generation ALK inhibitor as the frontline option, so thinking about ALK-positive patients who received ceritinib or alectinib as their first-line ALK TKI, what are their second-line options upon progression? Well, according to our FDA labels, the only one that has an FDA approval is lorlatinib. So that's FDA approved for patients who've either had crizotinib in a next-generation inhibitor or a next-generation inhibitor. So we're looking at on-label indications. That's our best option. Now, do we have any data with other drugs following next-generation inhibitors? Yes. So there's emerging data from brigatinib that the response rates are in the range of 20 to 40% following alectinib or ceritinib. And so I think that those could become options, although technically they're not FDA approved for that option. Are first treated with a next generation inhibitor, so for example alectinib or ceritinib, and they're progressing only in the brain. We're obviously wanting to use a next generation inhibitor we're obviously wanting to use a next generation inhibitor that has good CNS penetration. I think we have the most data to date with both brigatinib and lorlatinib, and it's important to keep in mind that lorlatinib is the only FDA-approved option. But I think both of those would be reasonable options to consider in a patient who's, for example, progressing on alectinib or ceritinib only in the brain. We know that both alectinib and ceritinib have good CNS penetration, so the progression that we're likely observing is true resistance and not lack of CNS penetration like we originally saw with crizotinib. In terms of choosing drugs based on side effect profile as a next generation inhibitor following a frontline next generation inhibitor, you may want to consider side effects. So for example, both alectinib and brigatinib can cause creatine kinase elevation in the blood. And so if patients had that with alectinib, you may not want to choose brigatinib as your next drug because they may run into similar issues. So I think keeping the unique side effect profiles in mind when moving to a new agent is important. When choosing a second-line ALK TKI for a patient who's started on a next-generation inhibitor, for example, alectinib or ceritinib, we can also think about using the resistance patterns as a way to choose the next line of therapy. So if a patient is on alectinib and generates a G1202R resistance mutation, lorlatinib may be the best choice. If you generate resistance via I1171 mutation on alectinib, you could use ceritinib, although brigatinib and lorlatinib also have activity against these, and so those would be reasonable. If we have a clearly defined bypass signaling mechanism, it may be that one of these next generation inhibitors will not work in the second line setting. I still think it's reasonable to try, again with close surveillance and understanding that there's perhaps a lower chance of seeing a response or long-term benefit in those patients.